Hello and welcome everybody. As Dr. Ayler just said, my name is Dr. Vivian Vega. I'm an infectious disease attending at the VA. I'm here to talk to you guys about Ebola virus disease, a bit of an update. This was meant for healthcare workers, but it has been edited for it to be adapted for pretty much a presentation in general. I'm going to talk to you guys a bit about the history of Ebola virus disease. We're going to talk about transmission. We're going to talk about Ebola in the US, highlight a few of the cases, etc., etc. We're going to hit on geography a bit as well. So let's start with the most recent outbreak, which is the one everyone is most interested in. And we're talking about the current called 2014 outbreak. The outbreak actually started in December of 2013, so this is something that we've been dealing with for a very long time. These numbers are continually updated. Every time I give this talk, the numbers change quite a bit. So far, there's been more than 14,000 cases that have been reported, and over 5,000 deaths associated with this particular outbreak, the 2014 Ebola outbreak. This hasn't only affected in these numbers, but there's a large component that has affected society in general in these countries. These countries are not only having to deal with Ebola, as you can imagine. It's actually a very small portion of what they have to deal with, and it has led to a displacement of public health resources in all these affected countries, resources that would ordinarily go to other illnesses which are actually higher, much higher in numbers, such as malaria, tuberculosis, etc. We're going to talk a little bit about this concept of what we like to call fear-bola, which seems to be spreading faster than the actual disease, especially as represented in the media in the US. And then we're also going to talk a little bit about what are we doing and how it has led to us having to reevaluate, are we prepared to deal with something like this here in the US. So a little bit of history about Ebola. So it was first discovered in 1976 in a town called Yambuku in Zaire. It was found along the Ebola. This is close to the Ebola River. Zaire is now the Democratic Republic of Congo. This is how you may know it now. And outbreaks of Ebola have actually occurred sporadically in Africa since the 70s, since 1976. A large number of outbreaks sporadically through Africa. Greater than 20 outbreaks, closer to more like 26 or so. It's a viral hemorrhagic fever pathogen, and what the name implies is actually what the virus causes, and I'll get into some of the clinical manifestations, pathogenesis of the disease, which is why it's called a viral hemorrhagic fever. It's a family of zoonotic RNA viruses. What that means is that it comes from animals, basically. It's a zoonosis. And it's in the family of Filoviridae. Since the beginning of it, it has been known as a severe disease with a very high case fatality. So I'm going to start here by showing you what I mean by all these previous outbreaks. It's definitely not the first time we see Ebola. So more than 20 previous Ebola and Marburg virus outbreaks. Let's focus on Ebola. And these dots here are going to tell us the previous outbreaks where they were located. And this is Yambuku right here, which is what I was talking about in 1976, the initial. And there's about 5 different known different types of Ebola viruses. This particular one in Zambuku, like I discussed, in Yambuku, I apologize, actually is the Zaire Ebola virus, and this is the same Ebola virus that we're seeing now here in the US. It's the same species of virus, same one from 1976. What we're dealing with now is West Africa. So this is also one of the biggest differences of when you take all these outbreaks into account. now geography has changed. We're in West Africa, so Guinea, Sierra Leone, Liberia. Like I said, it's a zoonotic, considered zoonotic virus. Scientists believe bats are the most likely reservoir, and it's thought to be a spillover event from infected wild animals. In other words, the initial patient comes in contact with a fruit bat or a primate. This is what we mean by a spillover event, and then from that point on it adapts to human transmission. So when we talk about natural reservoir, scientists, although it hasn't been finalized, we do believe that contact with fruit bats and primates may have been the spillover event. Another source when we say contact with wild animals, being around sick, contaminated or infected bats, but also this practice of bushmeat that is known in Africa, which is the consumption of wild animals for their meat. Right? It's not when protein is scarce, you pretty much find nutrition wherever you can, and this is traditional practice. It's not like you can go to your local Publix and purchase a steak or anything like that. So here you see a little bit of what I'm talking about. These are fruit bats, and somebody's preparing them basically, and this is what they're going to eat. So handling contaminated animals or eating undercooked meat from these animals is thought to be one of the ways it originated. I want to show you this map here because I thought it was it's pretty charged, but it brings home a lot of points. When we take, if you look at the lighter pink areas here, as I'm showing you with the mouse, this is the area where the fruit bat habitat is, which actually seems to coincide with all the areas where we've seen Ebola in the past and where we are seeing Ebola now. If you look at the lighter dots, these are the previous outbreaks, and I just want to show you here. So from all the outbreaks, starting in 1976 to the most recent ones, if you look at the numbers, all these outbreaks collectively have resulted in approximately 2,000 deaths, as I mentioned earlier. And if you can see the number of cases versus the red is deaths versus cases in the pink here. If we look at this 2014 outbreak, like I mentioned on the initial slide, the numbers are quite different. We're already with greater than 5,000 deaths, greater than 14,000 cases, and this is just one outbreak. I also wanted to drive home the point about the area of focus, right? So we're talking over here, West Africa, and we're talking about these three countries specifically. So Guinea, Sierra Leone, and Liberia. CDC just added Mali to the countries, and I'll go into that a little bit later, but really these three are the main areas where we have had high transmission since the beginning. And I think this is really important for us to know, for everyone to know. Africa is very large. These are the three countries of focus, and I'll show you some more on this later. It's important for us as healthcare providers and healthcare workers to really know what we're talking about when it comes to who's exposed and where is this coming from. It's funny to me when lawmakers, congressmen, for example, who are sitting there, they're grilling on these healthcare officials regarding Ebola, and you can't even either pronounce or say correctly the countries that we're talking about. The congressman that kept saying Guyana as one of the countries. It's not Guyana, it's Guinea. Guyana or Guyana, I don't even know which one he was referring to, is actually in South America, so a little bit of geography always helps. He also kept calling it Ebola, which I think most of us know that also not the correct pronunciation. But just focus on that geography when we're talking about transmission and exposure. This is a little summary of what we had as of November 2nd. We'll have to update this with the new events in Mali. But basically the main thing I wanted to point out here is that we did have a small outbreak in Nigeria, as you can see here. There were 20 total cases in Nigeria. It's been considered outbreak free, or the outbreak has been over since October the 19th. Same thing goes for Spain, just the one case, and Senegal, just the one case, and also outbreak free since October 17th. And then we will be adding Mali again to the list, and I'll show you a little bit more about that right here. So basically, we had a single case in Mali back in October. No further transmission was associated with that case. However, we've had a number of new cases there, and the CDC and Department of Homeland Security has added Mali to the list of Ebola-affected nations, for which we're going to be doing the enhanced screening and monitoring, just like we were doing for the other countries. And this is sort of the headline associated with that. So like I said, as of November 17th, people arriving to the U.S. whose travel began in Mali will be subject to the same screening and the same monitoring, meaning travelers will be monitored for the 21 days, and they will have daily contact with our health departments, and these are the established monitoring and screening, entry, and monitoring protocols. That they involve twice daily temps, symptom checks, and this is all coordinated with state and local public health authorities. So let's talk a little bit about Ebola virus in the US. I think this is sort of everyone's main point of interest here. And we'll go one by one, sort of discussing highlights of each. So basically, I'll update a little bit of this in later slides, but as of October 24th, Ebola virus had been diagnosed in the US in 4 people. So number 1 was the index patient that you guys remember, the man who traveled to Dallas from Liberia. This was Mr. Thomas Duncan. 2 healthcare workers which were associated with this one index case, and then a medical aid worker who traveled to New York City from Guinea, a doctor, which I'll go into the details of him as well. So let's start with Mr. Duncan. First case in the US. And you know, a little bit of background on Mr. Duncan, and I like to mention this in these talks because Mr. Duncan was vilified in the media and a lot of different perspectives on him coming in here, which I thought was a bit unfair. Mr. Duncan, the way that he was exposed, the way he acquired Ebola, per reports, was when he was in Africa. Him and 3 other gentlemen, were trying to care for this pregnant woman who was very ill and very symptomatic. They actually carried this woman to multiple different clinics or facilities to try to get her help. This is how they became exposed. She was very ill in her late stages. All 4 of these men, which includes Mr. Duncan, have passed from Ebola since then. So let's talk about him in the US. So on 9/20 he arrives in the US. Per reports, he was a febrile departure. On September 25th, he presents to his local emergency department. Now we're talking about Dallas, Texas. He wasn't isolated. There was a reported temp of 103, but most of his temps were less than 101. He presented with abdominal pain. He was diagnosed with a viral gastroenteritis, was given a Z-Pack, and sent home. Again, this is contrary to popular belief. Z-Pack does not cure everything. This is more evidence that Z-Pack is not the cure-all to every illness. It definitely does not kill Ebola. During this initial presentation, there was thought to be 48 persons exposed. None of these have become infected. He's home. He presents again on 9/28. At this point now, he's transported by EMS. He's very symptomatic. He's admitted with severe vomiting and diarrhea. This is a lot later in the illness and goes with the progression of this illness. It's thought that 76 people were exposed during this presentation, and only two of them, the two nurses that we know, were infected. He was diagnosed by PCR on September 30th, and unfortunately on October 8th he passed. One of the main things to highlight about Mr. Duncan is that unfortunately this is a very, very late presentation for Ebola. It's a lot harder to fight this disease even with our resources when you're presenting so late. I mean, we're talking 10, 12 days into his illness, not knowing when exactly he was exposed. It's a lot harder to fight it when you've gotten to this point in the illness. What's happening at the same time here with Mr. Duncan's family? So there was an enforced quarantine of the household. The household was not decontaminated. There was all these reports from the media about these people, they're leaving and they're not sort of having the quarantine enforced, or they're not being compliant with their quarantine, I should say. But there was no food provided for these people. There was a young child that was in the household. There was 4 in the household. You can't ask people to be quarantined if you're not going to provide food for them and their children. I mean, it's just common sense. But nobody mentions these things. There were 4 in the house, non-infected, like I said. So again, the total tally here so far with Mr. Duncan, our index case, 46 on initial presentation, 76 on readmission, and we have, out of all those, the 2 nurses that were infected. So let's talk about the nurses. The first nurse to be infected, Miss Nina Pham, she cared for Mr. Duncan from 9/28 to 9/30. She was diagnosed on October the 10th. She was treated and managed at NIH, recovered and was released from NIH on October the 24th. Second one was Miss Amber Vinson. She cared for Mr. Duncan while he was very symptomatic, copious body fluids. She was diagnosed October the 15th. She recovered and was released from Emory University on October the 28th. Both of them are doing well, thank God. These are true heroes, our nurses, our healthcare workers that decided they rose to the occasion and cared for Mr. Duncan. They both wore CDC recommended PPE, so they both did exactly what they had been recommended to do. There's some reports that perhaps their exposure occurred during doffing, and what doffing means is while they were taking off their personal protective equipment. There was also some reports about potentially some skin exposed around their neck. So, summarizing Ebola in the US so far, specific to Dallas. As of November 8th, all the Dallas contacts have completed their 21-day monitoring period. So we're talking about people that came in contact with these 3 confirmed cases. Known contacts and possible contacts, which were a total of 177, they have all completed surveillance. There was no infections. The 4th case in the diagnosed in the U.S., Dr. Craig Spencer, is a gentleman who was caring for Ebola virus disease patients in Guinea. He arrived at JFK Airport on October the 17th. And I did this slide this way on purpose. I kept it this way on purpose because I thought it was comical how the media practically stalked this guy, and we knew every single thing that was happening to him minute by minute. I mean, we knew when he went to the bathroom, we knew when he was eating, sleeping, everywhere he went, who he was talking to, who he was riding with. So on 10/21, he felt a little fatigued. I mean, he just got back from Africa from doing strenuous work over there. He visited all these different places. I'm not going to go into it. I just sort of put that there, like I said. On 10/22, he's still feeling fine. He was afebrile. He's doing his self-monitoring like we're all told to do, twice a day, temperature checks. Went for a 3-mile run. I mean, does that sound like somebody who's not feeling well? I don't think so. Yet we still have all this info on exactly where he's been. takes an Uber taxi home on the 22nd. If you've never taken an Uber, I highly recommend it. And then finally on 10/23, he's checking his temps. Has a temp of 100.3, which by the way is a very low grade. It's not even considered a fever by definition. Calls EMS himself and is taken to Bellevue Hospital in New York City. The most recent case that we had, again, was not diagnosed here in the US, but was brought and treated at Nebraska Medical Center. A doctor from Sierra Leone. This is Dr. Martin Salia, and I think it's good to show him in his picture because, again, these are our heroes. These are people that are battling that disease over there and are trying to fight this and stop it over there, which is what we need to be doing. So he was a native of Sierra Leone and a U.S. resident. He became infected while he was treating patients in his home country. Again, this is another story. I'm not going to go into all the details, but unfortunately, he wasn't transported or brought here to Nebraska Medical Center until very late in his illness. He was tested positive on the 10th, though he had been symptomatic for quite some time before that and had already had one PCR test that was negative on November the 7th. He arrived at Nebraska Medical Center for treatment on Saturday, November the 15th, approximately the 13th day of his illness. He was known to be critically ill and perhaps sicker than the first patients who had been treated in the U.S. The hospital in Nebraska had said on late Sunday of that week that he was in extremely critical condition, and then, like I said, unfortunately, he passed on Monday, November 17th. So as of October 31st, and now November 17th, Salia will be the 10th person with Ebola to be treated in the U.S. Again, I was differentiating between people diagnosed here and people that were brought here, already having a diagnosis to be treated here. So he becomes the 10th person with Ebola to be treated in the U.S. and the second one to have died. And what those two cases have in common, like I said, is that they presented very late in the disease. All the patients have recovered and have been released from the hospital. There's laboratory testing that has confirmed that they no longer have Ebola virus in their blood. Once you have it and you beat it, you're no longer deemed to be, you can't pass Ebola to anyone else. You're immune. So let's talk about transmission. I think this is one of the most important topics when it comes to Ebola. Certainly one of the most important topics when it comes to Fearbola. It seems like what you think about the transmission of this disease seems to be not based on science and more based on almost religious belief or party affiliation and politics. So let's actually talk about the science behind it. It's not so transmission, human to human. There's several things that are important here. So what body fluid are we talking about? There's highly infectious fluids versus not so infectious. So blood is highly infectious, body fluids, emesis, and feces of infected patients are highly infectious. You're contagious only if you're symptomatic. So this is another thing that is extremely important to address. Your contagious transmission is by body fluids, and it is with close contact with body fluids via mucous membrane, meaning eyes, mouth, nose, or a break in the skin. To give you a little more specific, so direct contact, like I said, through broken skin or unprotected mucous membranes. Can also have Sharp's injury, which are a lot of the hospital-associated cases, whether it's a contaminated needle or other sharp. Direct contact with the corpse of a person who died from Ebola virus disease. So this is really important in the sense that we have had in these past outbreaks, one of the main things that we worry about is the burial practices in Africa and how this has led to a lot of transmission in cases. So if you can imagine your family member just passed, you want to say your proper goodbyes. You want to be close to them. You want to kiss them and hug them and grieve over them. And this is when we were having a lot of cases, because you're very highly contagious at the time of death and sometime after death, especially if you're covered in any of these body fluids. And they were cleaning, and as part of the burial practices, they clean and kiss and come in close contact with the corpse. I'll show you some pictures later on what they're trying to do in Africa about that. Also, indirect contact with an Ebola virus disease infected patient's blood. So, for example, instruments that have been contaminated, if they come in contact with another patient, use utensils, soiled linens, especially if they contain blood. For example, that original outbreak that I had discussed in 1976 in Yambuku, it's a missionary hospital, and back then they knew nothing about Ebola. When you presented with a fever in that region, you were a lot more likely to have malaria, and it was practiced to just give anti-malarials via injection. They don't have the resources we have here, so it was common practice to reuse needles. So about 100 patients that were given anti-malarial agents with contaminated Ebola needles became infected with Ebola, and unfortunately all 100 of those passed. So more about transmission, the question everyone's been dying to know. Can you get Ebola from your pet, cat or dog or other? Well, like I said, initially we know that there's been transmission with infected fruit bats, associated with infected fruit bats and monkeys, primates, transmitted via their blood fluids or meat. However, there's very limited evidence that dogs become infected with Ebola virus. There's no reports at all of dogs or cats becoming sick with or transmitting Ebola, or being able to give it to you, or being able to acquire it. This came up when that nurse in Spain, when her dog had to be put away, if you guys recall that. So let's talk a little bit more about the fluids. Like I said earlier, highly contagious fluids versus less so contagious. Blood, vomit, and feces are going to be your highly contagious fluids. Urine, sweat, saliva, and tears less so. And then there's convalescent fluids, which that means this convalescence is the period when you're recovering from an illness. Semen, vaginal secretions, as well as milk. And in this graph, you can see actually how long the virus is present in these fluids. So we know that it can be present in the blood up to 21, 22 days. A lot less so in sweat, as you can see here, present for a long time in feces. Interestingly, and I'll let you read this slide on your own, and just want to point out here, symptom onset day 1, meaning when you become symptomatic, right? Because this is when you become when you're contagious, when you're able to transmit the virus. If you don't have virus in your body fluids, you can't transmit the virus. Somehow it can last in semen up to 84 days or so. Not really sure how they tested that or how that was tested, but this is some of the evidence that we have. It is not known, I get this question all the time, it is not known whether it can be spread through sex, intercourse, or oral sex, but men are recommended to abstain from sex for 3 months after they're recovering from Ebola. So guys, I know that's a hard task, but no sex for 3 months after infection with Ebola. If you absolutely have to, make sure you use a condom. So like I said, human-to-human transmission, you're not contagious until onset of symptoms. It's going to depend also on what body fluid and high versus low risk. We mentioned why the remains from diseased infected persons are concerned, because they are highly infectious. Again, another thing that has been mentioned a lot in the media, which again seems to be more of a belief of whether you're depending on your party affiliation than real science. There's no demonstrated human-to-human transmission of Ebola via inhalation or the airborne route, inhalation of aerosols. I wanted to add a few transmission studies that have been done, mainly to drive this point home of being around close somewhere to someone with Ebola doesn't necessarily mean you're going to get infected, even if you're in the same household sometimes. So a study in South Africa in 1996, there was a patient who was admitted for 12 days. It was an unrecognized Ebola case, so they didn't know about it until later. There was over 300 healthcare workers that were exposed at that time, and no infections resulted from this particular study. A study in the Congo in 1995, where they followed household contacts of Ebola virus cases, and these weren't the caretakers. There was a difference. The caretakers are in direct contact, but these were just household members, had no direct contact with body fluids. They were just in the same house, and there was no infections out of 78 persons in that household. This was an interesting article I wanted to bring up. There is an article about this woman in Africa who cared for and treated 4 of her family members, relatives, that had Ebola. She saved 3 of them. Unfortunately, 1 of them passed away. And what she used, she was a nursing student, garbage bags for her personal protective equipment was garbage bags like you see here around her booties here. She wore rubber boots. She had acquired gloves and masks from local clinics. Per these reports, she could hang IV fluids, etc. But basically, she nursed 4 of her family members, protected herself in this way, and this method is being taught to others in West Africa because, you know, the main things to know about this. Why do we need to teach this to others in Africa? Is because some of the last statistics, it's something like 2 doctors per 75,000 patients. I mean, if you can imagine, it's not really the way healthcare works here in the U.S. When you talk about somebody being treated for Ebola at Emory, we're talking about 300 healthcare workers for 1 patient. I mean, think about those ratios and the reverse of it. So they're actually trying to teach this to others because they can't get to everyone. We're seeing reports of family members bringing their loved one in a wheelbarrow to the nearest area and having to be returned because there's just no room for more people. Which brings us to why it's important to know that we need our healthcare volunteers, and we need to make it easy and safe for them to feel comfortable being there. This is the nurse Kaci Hickox, who you guys probably heard about in the news. I'm sure she was caring for patients in West Africa, and upon return to the U.S. in Newark, she was placed in forced quarantine. She was asymptomatic at that time. Governor Christie placed her in quarantine. Some thought everything that had gone on with her case had some political overtones. But the main thing to say about her is that instead of going on about how she was refusing quarantine, I mean, let's talk about what she really needed. She's a true American hero. I mean, was risking her health and life by fighting the spread of Ebola in Sierra Leone. I mean, how is she different than military personnel that we have to show so much respect to, and we should, of course. She was credited by many, but then criticized for her activism. What she was trying to do wasn't only for herself. She was basically trying to protect not only her individual rights, but those of she's trying to set a precedent for other healthcare workers returning from West Africa who are trying to help stop this epidemic. And what we need people helping there to stop it there. If we don't stop it there, it's only going to make things worse. So when we talk about these forced quarantines, the general medical community, the New England Journal of Medicine just had a great article on this. Forced quarantine is not only not scientific, it is unfair, it is unwise. Basically, all it does is impede all these efforts to stop this awful outbreak and what we need to do over there. What we should be doing is honoring these healthcare workers, not quarantining them. They're trying to fight the source control, and the source control is over in Africa. Just a little bit more about this fear Ebola epidemic that I keep bringing up is there was that example of this 7-year-old girl who was banned from school because she had traveled to Nigeria. I told you guys in the beginning of the presentation, Nigeria has been certified Ebola free by WHO since mid-October. There was another story about a teacher in Maine, a school board that put this teacher on leave because she had attended a conference in Dallas that took place 10 miles from where the index patient had died. I mean, come on, people. Seriously? These are some of the things of how it gets out of control, and we need to really go by facts and by the science of the disease. This is a little cartoon I pulled up that I thought was relevant and pretty hilarious of what's been going on here. I'm going to skip through this, but basically I already went over the difference between a high risk exposure, low risk based on fluids, based on obviously whether it's a needle stick, direct contact, splash type of exposure onto you, onto mucous membranes, or broken skin. Especially high risk, obviously, if you're not wearing your personal protective equipment, obviously that would be considered a high-risk exposure. Other high-risk exposures were, as I mentioned, was direct contact with a dead body, including during funeral rites. So this is more for the clinicians in the audience. I'll just briefly go into a little bit of this. A little bit of the pathogenesis of Ebola virus. So basically, whatever the portal of entry of the virus is, what happens next is that there's direct infection of the cells. So it enters the cells. The first cells thought to be infected are macrophages and dendritic cells. This is followed by rapid spread of the virus, and it's felt to be secondary to a suppression, direct suppression of the virus by the virus of these type 1 interferon responses. That leads to rapid spread. Of course, if a lot of cells are dying, there's tissue damage. Then there's a systemic inflammatory reaction like you see with most cases of sepsis. Release of cytokines, chemokines, other pro-inflammatory mediators, which then leads to, if it continues to progress, will lead to hypovolemia, vascular collapse. A lot of third spacing, and I'll go into specifics of cases treated here in the U.S. You'll see a lot of electrolyte abnormalities, eventually multi-organ failure, septic shock. So hemorrhagic fever, like I said in the beginning, therefore, disseminated intravascular coagulation, DIC, and coagulopathies. There's different ways. The extrinsic pathway is directly activated by factors produced by cells and with the virus infection. And also, towards the end, if liver pathology may lead to coagulopathy as well. There's also a degree of immune dysregulation that comes along with this. So that was quick, right? Painless. Let's talk about how the patient is actually going to look. How are they going to present? So basically, it's an acute presentation. On average, 8 to 10 days after exposure, but it can happen anywhere from 2 to 21 days. The main signs and symptoms initially are a flu-like illness, what we call a flu-like illness, meaning fever, chills, myalgias, meaning muscle pain, malaise, feeling tired, anorexia. After 5 days or so of that on average, then really the symptoms that are going to predominate are GI symptoms, so nausea, vomiting, watery, diarrhea, abdominal pain. Other less so, but still potentially present: headache, conjunctivitis, hiccups, rash. I'll tell you about, discuss in brief about Dr. Brantley, one of the first cases that we treated here, and he had a petechial rash that was associated with his illness. Can also have shortness of breath, confusion, and I'll talk about the specifics of that. For this particular outbreak, hemorrhagic symptoms were reported in 18% of cases. Hemorrhagic meaning bleeding from any site. So when you have this kind of presentation in Africa, for example, and depending on where you are, as far as epidemiology and geography, it can be a lot of other things. It could be malaria, typhoid fever, meningococcemia, Lassa fever. It could be septic shock or sepsis from pneumonia and bacterial pneumonia. These are all very common in Africa, so it's not all going to be Ebola, and if you can imagine how it could be very difficult to determine this up front. However, big difference if you're in the US. So if you feel sick, and you're looking at this and you're listening to this, you feel sick, think flu, not Ebola. Big difference here. In the US and in most areas in Africa that are not these three areas in West Africa. Think about it in this perspective. Each year in the US, millions of people are infected by the flu. Hundreds of thousands are hospitalized. Tens of thousands may die from the flu each year. I mean, think about those numbers and think about the panic the fear Ebola in the news, and this all these accusations about us not having a vaccine, and how dare you, when I just told you tens of thousands die from the flu in the US yearly, and I bet most people don't really care to get their flu shot. We all get it, we're healthcare professionals, but think of these numbers in that perspective. So other clinical features, like I said, if it progresses, you'll see more of a hypovolemic shock type of picture leading to organ failure. And we talked about this. The only thing I'll highlight from here is typically the people that are going to make it, they start to improve 6 to 11 days into after symptom onset. So 6 to 11 days into their illness. They start to improve, they have a much better prognosis. These are symptoms, clinical manifestations, again, in just a different form, chart form for you guys. You should have the handouts. Examples of hemorrhagic signs. I think most of us know what these look like. Basically, you can see some oozing here around the IV side. It's a hemorrhagic fever. There's coagulopathy associated, so you'll see that bleeding in the gums, vomiting with blood. What are you going to see in the lab? So again, more for the clinicians in the audience. You're going to see low platelets. That's thrombocytopenia. You're going to see low white blood cell counts. You're going to see an elevation in the liver enzymes, and the pattern is going to be AST greater than ALT. You're going to see a lot of electrolyte abnormalities, and I'll mention that in more detail. And like we've been saying, coagulation issues, PT and PTT will be prolonged. Renal abnormalities, including proteinuria, and of course increased creatinine. If you have hypotension and shock, it's not surprising that you'll have some degree of renal failure associated with it. Let's talk about diagnostics. So again, when we talk about virus present in fluids, we're talking about symptom onset. So let's start here, day 0, and what you're going to see is the amount of virus present in the blood is going to peak at about day 4 or 5. This is when your PCR is going to be the most important diagnostic tool. Day 0 meaning here onset of fever or symptoms. Then a little later, like with most illnesses, you'll see an increase in the IgM, which is first antibody, and then increase in the IgG. You can test these with ELISA. Only other thing to point out here is that once you develop your IgG can be present for many, many years. Some of the studies show it to be present for 12 years. So you have immunity to Ebola that we have strong evidence for about 12 years. But there's some question about potentially lifelong persistence, so immune for life. And these are the types of patients that we are now sort of in the front line trying to fight Ebola in West Africa. They're immune, so they're not at risk for getting the disease again. A little bit more on the PCR is how we're going to diagnose Ebola. Real-time PCR. It's used in the acute infection to diagnose it. It's more sensitive to antigen detection. ELISA, like I said, it's also going to be a lot earlier for reasons that I just showed here on this slide. There's some details here on sample collection. You can guys look at that on your own later. I'll skip through that. And then other ways of diagnostics, you can isolate the virus. This, of course, is going to require biosafety level 4 laboratory. Can take several days. And you can do immunohistochemistry. And, of course, you can diagnose by serology. But like I said, it's going to take a lot longer to do it this way. And just a quick thing on PCR and interpreting it for clinicians. If you have a patient who has been symptomatic for over 3 days and you get a negative PCR, you can rest assured that Ebola virus is highly unlikely. However, the other situation is if symptoms have been present for less than 3 days and you get a negative PCR and you still think Ebola, I mean that's like Dr. Martin Salia, this was the case for him, then you should definitely, if you're still very suspicious of Ebola, you should definitely repeat the test after 72 hours, because I showed you on that other slide that viremia is highest and it peaks after day 4 or 5. You should probably keep that patient in isolation as well until you get that repeat test. Clinical management of Ebola virus, again, from the way that it presents and pathogenesis, what we discussed, you can sort of guess how this is going to be. So very aggressive supportive management, support their blood pressure, correct electrolyte abnormalities, manage the symptoms, treat the fever, treat the diarrhea. If they go into multi-organ failure, then they may need additional help. If they have coagulopathies and bleeding, for example, then they may need FFP, platelet transfusions, etc. And I'm going to talk to you guys about this in more detail now when we talk about a real case. So New England Journal of Medicine published an article recently on the care of 2 patients with Ebola virus disease in the U.S. I'm not going to go over into all the details, but let's talk a little bit about Dr. Brantley, who was our first case. He was transferred to Emory University Hospital. It was about day 10 of his illness. He had been working in Liberia. Dr. Brantley had actually been in West Africa since October 2013, before the Ebola outbreak started. When he was transferred here, he received some treatment over there. He was transferred to Emory, so I'm only going to discuss things specific to Emory and not in detail, just to give you an idea. So there was some clinical evidence of him being hypovolemic. He was orthostatic. He had resting tachycardia. Despite the fact that he was swollen, he was very edematous, 3+ pitting edema all the way up to his waist. He was aggressively resuscitated with fluids. And even after that initial fluid resuscitation, he was found to have frequent PVCs, up to 6 episodes per minute. A lot of what we're seeing now with these patients is that these fluid shifts and the severe third spacing is leading to a lot of electrolyte abnormalities, and that this is actually more relevant to complications and death than even the later stages of disease. So to correct Dr. Brantley's hypokalemia, he actually was receiving 80 to 100 millimoles of oral potassium supplementation daily for the first 5 days of his hospital stay here. He was having a lot of diarrhea, a total output of 2 to 4 liters of stool per day. That's a lot of diarrhea. If you can imagine, it's hard to keep up with that. So to replace all his fluid losses, he was requiring 2 to 5 liters of IV fluids a day, plus he was getting oral intake. And this was all the way up until day 17 or so of his illness. That's a lot of supportive care. And this is a young guy, 33-year-old, healthy guy with no known comorbidities. So what do we have as far as therapies for Ebola? There's nothing that has been approved. There's no specific Ebola prophylaxis or treatment that has been approved. We have some things that we think may work, some things that are in development. I'll just mention some of these here. Convalescent serum, meaning we're giving patients transfusions from other Ebola cases that have survived it, so we give them their antibodies basically. We give them convalescent serum and treat them with antibodies of people that have survived it. Dr. Brantley's serum was used to treat other patients with Ebola here. There's some therapeutic medications. You guys have probably heard about ZMapp. This is a cocktail of monoclonal antibodies, basically. Dr. Brantley received ZMapp. Along the way, there's also Ticmira. This is a lipid nanoparticle that is supposed to interfere with the RNA of the virus. And others here that I'll just have you can read about them, look at them. There's also some vaccines that are in clinical trials right now. Two different ones, as you can see here, chimpanzee-derived adenovirus. And basically what they do is they just insert a gene from the Ebola virus into another sort of vector and help an antigenic response to this will recognize it with the Ebola gene inserted to it, and that's how you make your vaccine. And then there's another one with vesicular stomatitis virus, but again, they're early in clinical trials. The case fatality rate for this outbreak has been reported in a lot of these studies to about 70 in the 70s, so 71 to 78%. However, this is based on studies in Africa. The fatality rate is much more lower. It's likely to be much lower with access to intensive care facilities, and I'll show you what some of the facilities in Africa look like, so you can see how it's a very dramatic difference being treated in Africa versus being treated here. The fatality rates may be a lot different, like we discussed. Even in the 10 cases in the US, 2 of them passed, and they both presented very late. Like I said before, patients who survive the disease usually have signs of improvement by the second week of illness. So that's usually a good prognosis. So what are we doing here to screen? So basically, all of us as healthcare providers, we need to know how to screen a patient. Is this relevant? Is there even a potential Ebola exposure that's relevant here? So you ask patients, we're going to go over the algorithm and more in picture form. So basically, here's where you start, and we're going to put these on. We already have these on clinics, nursing stations, ER, outpatient clinics, etc. And everyone should be familiar with this. So, does a patient have a fever, as stated here, or compatible Ebola symptoms? So all these symptoms that we have discussed in a patient who has traveled to or has lived in a country with widespread Ebola transmission. We talked about what those 3 countries were. And the period of time that you're interested in is the 21 days prior to illness onset. Some of the symptoms are mentioned here, but I've talked about these. If the answer to both of these is yes, then you isolate the patient, escort them to a single room with a private bathroom, implement standard contact and droplet precautions, put on your PPE before any further interaction with the patient. Notify the hospital infection disease team here at the VA. We have our own protocol of what the contacts are and the numbers. I won't go into that obviously, but and then if any of these, if 1, they're not symptomatic, or 2, they haven't traveled to any of the endemic countries, then the answer is no. If they don't even fit the criteria for traveling to any of these countries, then really it's going to be something not Ebola. Again, just to remind you, these are the 3 countries of interest that we're talking about in West Africa. So again, Guinea, Sierra Leone, and Liberia. We just added, CDC just added Mali to the list, but there's really hasn't been that many cases. This is Africa. Just to remind you, we're talking about a very, very small area in West Africa. I personally love this map, just to put everything in perspective. The only thing about would be to add Mali here to this map. But as you can see, we're talking about a very, very large, when we talk about travel to Africa, this is a very small area, small section in Africa. I mean, this is a continent. No Ebola in most of Africa, so it's a very small point. So you can't, this isn't about, oh, has anyone traveled to Africa? No, it's very specific about these 3 countries. I thought this was a very interesting, sort of a cool pictorial here, showing us how large Africa is when you think about it. It's a continent, not a country. You can fit all these nations into Africa. When you think about it that way, I mean, this is how large Africa is. So when you think about anyone traveling, if you're in this area of Africa, does it even make sense to think that they could have potentially come in contact with anyone here? No, I mean, we're talking about thousands and thousands and thousands of miles away. So here you can see the US fits in here, Spain, France, Germany, Italy, Eastern Europe, India. We had to kind of break up China here into 2 so that it could adapt to the map here. So as you can see, I mean, we're talking a very, very large area. I'll skip to this. Is more relevant to our hospital here. I just wanted to share some pictures with you guys about, so you get an idea of what we're talking about the conditions and how care in Africa is going to be a lot different, despite the fact that we have all these great, courageous, knowledgeable healthcare professionals in Africa. The conditions alone just make things very difficult. So this is a picture of contact tracing, and this is a very important part in epidemiology and trying to stop this outbreak, is identifying people who had potentially been exposed. If you can't get to all these people, there's always going to be a potential for exposure. Again, this is just checking temps, monitoring patients. These are hand wash stations that are present in a lot of areas in Africa, and you can see these throughout Africa. But these are different in the fact that it's chlorinated and it adds a special solution, which more Ebola specific. Which, by the way, any household disinfectant, if you're wondering about what you would do to protect yourself, any household disinfectant can kill Ebola. I mean, your Clorox wipes at home, bleach, hydrogen peroxide, any of those would work. If it says, a lot of these on the label say it will kill 99.9% of viruses, including norovirus. If it kills norovirus, it will definitely kill Ebola. Norovirus is a lot harder to kill than Ebola. This is, again, when we're talking about the disposal of dead bodies and how to handle them, and and as you can see here, the healthcare workers fully suited up, trying to dispose of bodies so that it's not left up to the family members and more infections occur. This is an example of one of these treatment centers in Africa. I mean, I don't even like looking at this picture. Look at the difference. I mean, does this look like any hospital here in the US, any clinic? There's people back here on the floor, here, diarrhea on the floor. I mean, you know, when we talk about how vastly different the conditions are, this is a little bit of what we're talking about. Meanwhile, in the US, this is what's happening. So, I mean, it looks like a Halloween costume. I won't go into. We already discussed about regulating travel and how that would actually be bad for this outbreak, but Africa, U.S. So, wrapping things up here, basically, to control Ebola in the U.S., we have to stop the outbreak in Africa. It's like putting out a fire. You gotta stop the sparks so you can put out the fire. It sounds pretty simple. Summary slide, basically, this is the largest outbreak of Ebola that we've seen in history. Has affected multiple countries that we discussed. For healthcare workers and providers, think Ebola. You should know how it presents. You should know about the countries with high transmission and how exposure is relevant or not. Know that human-to-human transmission occurs by direct contact, like we discussed, with body fluids, via mucous membranes, or intact or broken skin. Correction. There is no human-to-human transmission via inhalation of aerosols, meaning the airborne route. Also, you're not contagious until you're symptomatic. That's another big thing. And most importantly, to be able to stop this outbreak is all these things together. Identifying cases early, isolating them, doing the contact tracing, and of course, treatment and infection control are going to be essential to prevent transmission of Ebola virus. Just wanted to end with this picture here, some of the new faces of Ebola in the U.S. So basically, this is Dr. Kent Brantley here, the 33-year-old. We mentioned his case. Nancy Warhol, the two nurses that we went into detail, Dr. Craig Spencer, and again, all these healthcare providers and heroes to us, and the nurses definitely deserve a lot of credit for what they did, especially without ever seeing this disease before. And that's the end of my presentation. I'll be happy to address any questions anybody has. Thank you very much. I appreciate your attention.